Hi again. In this video I'll be going over COPD, which is short for chronic obstructive pulmonary disease. Before I begin, don't forget to like and subscribe, and links to my Instagram, Facebook and Telegram are in the description below. So I can keep releasing these videos for free, please support the channel on Patreon. I'll put the links in the description below, and thanks in advance. I'll talk briefly about the essentials of COPD and then cover the causes, risk factors, signs and symptoms, and the investigations we use. We'll go over the management of stable COPD. We'll cover the long-term oxygen therapy. We'll cover the complications before finally going over the acute exacerbations that will usually present to us in the ER. COPD in itself, as we can tell from the name, is an obstructive disease in which there's permanent airflow obstruction, and this mostly occurs in chronic smokers. And what I mean by chronic smokers are those who've smoked for 10 to 15 years. COPD is an umbrella term as it is divided into two diseases, chronic bronchitis and emphysema. Patients usually have both, but they can present with either one. Chronic bronchitis has a clinical definition, whereas emphysema has a histological one. In chronic bronchitis, there's excessive mucus secretion plus daily productive cough for at least 3 months in at least 2 consecutive years. In emphysema, there's destruction of the alveoli, and this reduces the surface area for gas exchange to occur, so therefore less oxygen can diffuse through the alveolar membrane. This is what a normal bronchi would look like that isn't obstructed. You can see that the airway is patent, allowing air to move freely to and from the lungs. In chronic bronchitis, there's inflammation and excessive mucus secretion due to hypertrophy of the mucus gland. The inflammation causes the epithelium to thicken and obstruct the airflow. In emphysema, it's a bit different. Here you can see the intact alveoli and its membrane in a healthy person. And in emphysema, the alveoli and its membrane are destroyed, leaving less surface area for oxygen to diffuse from. When it comes to causes, the most common is chronic smoking, but people who live in areas of high pollution and those who have jobs where they're constantly exposed to dust, chemicals and fumes can also get it. In risk factors, the risk of getting it increases with age, and it mostly occurs in males than females. Low birth weight and premature babies are also at high risk. Asthma can put you at risk of getting COPD, and it can also coincide with it. We call this asthma COPD overlap syndrome. In alpha-1 antitrypsin deficiency, there's a deficiency in the protein that protects the lung from inflammation. They present with productive cough, shortness of breath, tachypnea, use of accessory muscles, and on physical examination, we'll find the chest to be hyperresonant on percussion. You'll hear a wheeze on auscultation, seeing as it's an obstructive disease. They can present with right ventricular enlargement, seen on ECG, which we call cor pulmonale, which is more of a complication than a symptom. If you look at these symptoms and signs, they are quite similar to what someone with pneumonia will present with. What differentiates it from pneumonia is that in pneumonia there's fever, and in COPD there's no fever. When it comes to investigations, we'll do CBC, which will show a raised hematocrit. Pulmonary function test. In spirometry, we'll find a low FEV1-FVC ratio, and there's a reduction in the diffusion lung capacity, especially in emphysema, seen as there's a reduced surface area for oxygen to diffuse from. ABGs will show a low partial pressure of oxygen and a high partial pressure of CO2. We'll do an ECG to look for cor pulmonale, indicated by right ventricular enlargement. Sputum culture will help to rule out any infections like pneumonia, and on imaging we'll perform chest x-ray or CT. So in spirometry, you tell the patient to breathe through a spirometer, and the reading will show an obstructive picture. The FEV1 is significantly reduced, and so is the FVC. The slope is also more gradual and less steep than normal, and in these patients their FEV1-FVC ratio, which should be below 70%, just like in asthma. But if they were to use a salbutamol inhaler and then get tested again, there should be a slight increase in the FEV1, but only slightly, not to the same level as asthma, which will show an increase of around 12%. When it comes to the diffusion lung capacity, you normally have oxygen going one way and carbon dioxide going the other way. In these patients, especially those with emphysema, there's destruction of the alveoli and therefore less surface area for oxygen to diffuse from. Okay, this is a normal X-ray. The diaphragm is concave and not flat. And if you look at the lung markings, they aren't hyperinflated. And there's no increased pulmonary vascular markings. In this X-ray, the patient has COPD. You can see a flat diaphragm, hyperinflated lung fields, and increased pulmonary vascular markings. This is another X-ray of a COPD patient. And this patient has a large bulli in the right lung, and if you look closely you can see the outline of the sac. When it comes to management of stable COPD patients, we begin with non-pharmacological treatment. Seeing as the damage is irreversible, the aim is to stop disease progression. The most important treatment is to stop smoking. They should be vaccinated against pneumococcal and influenza because an infection can exacerbate the disease. Pulmonary rehabilitation and physiotherapy will help them clear out any built-up mucus. If they still have breathlessness that limits their daily activities, we'll move on to pharmacological treatment. The mainstay of the treatment is to use bronchodilators to help relieve symptoms. We'll first give either a short-acting beta-2 antagonist like salbutamol or a muscarinic antagonist like ipratropium. And if that doesn't help relieve symptoms, we'll see if they're using the proper inhaler techniques. If they are, we'll give both long-acting beta-2 antagonist and long-acting muscarinic antagonist. And if that doesn't work, we'll do a 3-month trial of inhaled corticosteroid and see how it goes from there. You can also give them mucolytics to help decrease the mucus build-up. Long-term oxygen therapy is given to COPD patients with severe chronic hypoxemia. And the patient must be clinically stable and he shouldn't have experienced an exacerbation for at least 5 weeks. They also mustn't smoke due to it being a fire hazard. It's a lifelong therapy and it's known to increase survival if used for at least 15 hours a day. The indications for long-term oxygen therapy all depend on the readings on the ABGs. The reading must be constantly low on 2 separate readings that are 3 weeks apart. The partial pressure of oxygen must be less than 7.3 kilopascal despite maximum treatment, or between 7.3 and 8 kilopascal, and also have either secondary polycythemia, peripheral edema, or pulmonary hypertension. The complications include acute exacerbation, which I'll talk about next, respiratory failure, pneumothorax, which will show a bulli on chest X-ray, cor pulmonale, polycythemia, and lung cancer. An acute exacerbation of COPD is usually triggered by an infection, whether bacterial or viral, hence why we tend to vaccinate COPD patients against pneumococci and influenza. Their usual symptoms would have worsened, so they'll have more productive cough, severe shortness of breath, tachypnea, more prominent use of accessory muscles, etc. We'll need to request CBCs looking for raised white blood cells, and if there's purulent sputum, we'll do a sputum culture looking for an infection like pneumonia. We'll do ABGs focusing on the partial pressure of oxygen to see if they need any supplemental oxygen. In chest X-ray, we'll look for pneumothorax or an infection. In managing these patients, we'll first give them nebulized bronchodilators, both short-acting beta-2 antagonist and muscarinic antagonist. If the oxygen saturation is less than 88% and the partial pressure is less than 7 kilopascal, we'll give them oxygen supplementation to keep the saturation between 88 to 90%, or the partial pressure more than 8 kilopascal. We'll then give them IV hydrocortisone and oral prednisolone together. We'll give antibiotics if there's any evidence of infection. We'll have them do regular physiotherapy, which will help them be able to expectorate the built-up mucus more easily. And if they don't respond to any of the above, we'll give them IV aminophylline. If they still don't respond, we'll use non-invasive positive pressure ventilation. Or if that's not available, we'll give them doxapram, which is a respiratory stimulant. And as last resort, if all else fails, we'll intubate them and put them on invasive ventilation. We'll only put them on invasive ventilation if non-invasive ventilation has failed to improve the patient's status, or it's contraindicated, like in respiratory arrest, impaired consciousness, or if they've got a high risk for aspiration. Seeing it's invasive, there's a high risk for complications to occur, such as the risk for getting pneumonia or barotrauma due to the air pressure causing injury to the lungs. And that's it. I'll go over both bronchiectasis and cystic fibrosis in the next video.